We all agree that bleeding in spine surgery is a major concern, as pointed out by Dr. Paru. And it's a concern in every procedure related to spine. Even if you look at the percutaneous biopsy for doing for tuberculosis or for tumors, they can bleed. Potentially they all can bleed, and they all can create problems. So the important thing is to realize in spine is to predict that which cases they are going to bleed, and then you have to adopt the prophylaxis. And then the second thing comes the management of bleeding on a war scenario when you see or encounter the bleeding intraoperatively unexpectedly. So for prophylaxis, it is mandatory to get the proper blood coagulation workup, even if before doing biopsy. Get a PT or the hepatitis test, root out liver diseases, and look at the list of drugs if the patient is on, like rifampicin and all those things. They all affect the liver metabolism, and they can all affect the drugs, whatever they are taking, their metabolism, and they can affect the coagulation profile of the patients. So important thing is to predict that these patients, they are going to bleed. And then comes the importance of positioning. We have repeatedly emphasized the importance of positioning in all spine surgeries, especially like when you are doing a lumbar spine surgery, that your abdomen should be free. There should not be any pressure on the abdomen. And also when you are doing the spine surgery, then the reverse Trendelenburg position is very, very important to keep the bleeding affecting your choice of affecting your surgical field also to the great extent. One thing very important is that many of our patients, whether of the degenerative spine or of chronic pain, they all are taking antidepressants, especially the gabapentins, the pregabalin, and they all affect the bleeding because they all affect the serotonin uptake inhibitors. They all have some sort of serotonin uptake inhibition, and they affect all the platelet function, and they all can create the risk of abnormal bleeding during the spine surgery. So one has to be very careful while taking history that what drugs these patients they are on. The another important thing is whenever you see these calcified vessels, then you have to be very, very careful that because if you are planning to do any osteotomy, then especially which lengthens the anterior column, then these calcified vessels, they can break and then they can cause torrential hemorrhage. So that's why the Smith-Peterson osteotomy has been now forbidden, especially in ankylosing spondylitis, because they created some of the cases with torrential hemorrhage because of the very high incidence of these calcified vessels in ankylosing spondylitis patients. If you are operating a tumor, or if you are expecting that there is a vascular lesion, then it is always mandatory to get a preoperative embolization. And this preoperative embolization is can be a very effective tool to decrease the bleeding. You can see that this was a case of angiofibroma, which we get the preoperative embolization, and you can see that the embolization, how effectively it decreases the blush or the vascular flow in this tumor. And it is also important to realize that usually up to 72 hours the surgery is this bleeding control is effective. But if you operate these patients after 72 hours, then by this period the patients, they develop the collateral circulation, and then the effect of this embolization is not much. So always plan to operate within 3 days whenever you are doing an embolization. This is again a very big vascular tumor of involving the L5 vertebra. You can see that was a big tumor, and again we did a CT scan, the MRI, and we could see that it was quite vascular, and you can see that there were multiple feeders into this tumor. So we again did the embolization, and when we did encountered a very few bleeding and very less bleeding, and the whole surgery was just over with 300 to 400 ml of the blood loss. A big tumor was taken out, including the L5 vertebral body, partial L5 vertebral body, and you can see that we could achieve a good bleeding control hemostasis just by doing the preoperative embolization. And this came out to be as an angiolipoma, that it was full of the blood vessels during the surgery. And this is again a case of an aneurysmal bone cyst. And again, one of the strategy to deal with these tumors is that you do not expose the tumor at all. You start your surgical surgery lateral to the tumor, and then you proceed from lateral to medial, rather than the traditional going from medial to lateral. Like in this, you can see that we have isolated this whole tumor. I have not exposed any of the tumor part, and I just cut the ribs laterally, and then I lift the tumor from the lateral to the medial, and then we take out the whole material in a single en masse. You can see here, and this is the final construct you can see after this tumor removal. Now coming to the another tumors which are a big concern of bleeding, the vertebral hemangiomas, and this problem has been solved by our neurosurgery department at AIIMS, and they have published this fantastic technique of using the absolute alcohol injection. Like this was a case of an aggressive hemangioma, and usually if you look at the literature, the traditional surgeries, they are minimum blood loss, they cite about 2 to 3 liters at least, and then even then the outcome is not good. But with this technique now the bleeding is quite less, and you can achieve a good outcome. So what we do, we inject, we put 2 screws above and 2 screws below, and we just put the Jamshidi needle, the traditional MIS Jamshidi needles into the vertebral body, and then under the guidance, we put the absolute alcohol. So you can see that how much bleeding it was coming up, and then we inject the alcohol, absolute alcohol. And one has to be very careful that at one single time we just inject 0.1 ml of alcohol, and we keep on flooding the surgical field with the saline, because this absolute alcohol can be very dangerous to the tissue. And we don't do the laminectomy until we are done with the absolute alcohol. And then you can see that and actually you can see here that when we take out the needle from the other side, then there is hardly any bleeding now, because from the one side alcohol sometimes it is sufficient to control the bleeding from the other side. From the other side you could see that how the blood was coming up, and when we do the laminectomy, then you can see that there is hardly any bleeding. So now the surgery which used to take 2 to 3 liters of blood at least, now it can be done with less than 100 ml or 150 ml blood loss. Now this is the preoperative and the postoperative CT scan. You can see that the adequate decompression and as well as of the canal, that the whole the vascular plexus has shrunk into this thing. Now this was another case of a vertebral hemangioma in a pregnant female. She came to us with third trimester, and because of the abdominal, the pressure on the vena cava, these vessels, the hemangiomas, they enlarge. So they are very common in third trimester of pregnancy. So we operated this lady in the lateral position. And this went well. Normally I inject some cement, but now Dr. Sharath has again published that this is not essential, and just putting alcohol with 2 screws above and 2 screws, they are just sufficient. In long term, this bone reconstitute actually in long term. Coming to the anterior approaches, the segmental vessels, they are very important, and this you can see here that this is the aorta, and these are the segmental vessels. One has to be carefully identify these things, and then either you can use the bipolar, and my preferred choice is to ligate them, and then you cut in between. You always leave a sufficient pedicle on both sides, so even if your ligature slips, you should be able to control it. These segmental vessels, and these segmental vessels, they are very, very important in posterior exposure too, especially you are planning the osteotomies. Then these segmental vessels, if you are not careful, they can just slip anteriorly, and then they are very difficult to control, and then they can keep on bleeding, and it can be a cause of concern during the surgery. This was again, if you're operating tumors in the spine anteriorly, then exposing these vessels again becomes of paramount importance, and also to separate the tumors from the surrounding vessels is again important. This was a case of a giant cell tumor of the thoracic vertebra, which we removed with proper care of the segmental vessels. Now, sometimes the tumors, they also involve a large ribs along the spine, and when you are taking out these large tumor masses, then again you have to be very, very careful of the intercostal vessels. Like this is the cranial side, and this is the caudal side, and you can see here that this is the cord here, which I've done the thorough decompression. And in these cases, it is important that you first do a complete laminectomy, and you identify from medial to lateral the intercostal vessels, and then you ligate the intercostal vessels, and then you have taken out the whole tumor. And you can see here that if these intercostal vessels, they can also bleed a lot if they are not properly taken care of. Coming to major vascular injuries, again, prophylaxis is important. So always anticipate, look at your preoperative imaging. You can pick up, the abdominal aortic aneurysm sometimes during your simple disc surgeries. And always take control of vessels. If you're working in a vicinity, especially in the anterior surgery, always take control of the vessels proximally as well as the distally. Now, if you have a major vascular injury is intra-op, then the options are very limited. Packing is the most important thing. Call your vascular surgeon friend, then you can explore, or you can directly repair or the graft, and you can always do the endovascular management if you have the facility with your vascular colleagues. Now, coming to this thing, like this was a case of lumbar scoliosis, you can see, and this was a case of Marfan syndrome. So always take care when you look, when you heard hear the name of these Marfan syndromes, neurofibromatosis, because they always have, the major vascular anomalies. Now, this looks like a simple lumbar scoliosis case, but if you look at the rotation, if you look at the rotation of the lumbar, so there is a significant rotation, and when we actually put the patient prone, we can actually see the pulsations, of this thing. So we were actually very skeptical, and we were very careful while exposing. And when we exposed, actually there was so much rotation that the aorta was rotated almost, it was coming to the dorsal spine, and it was just adjacent to the, you can see here, it was just adjacent to the transverse procession. So again, you have to be very careful that whenever you are doing these sort of cases, then you have to be very careful, especially in the extreme rotational deformities. Now, this was a case of a recurrent giant cell tumor. First, we operated this patient 5 years back. We did a posterior surgery, and the patient was doing fine. But then she had a recurrence in the anterior ala. So we had to go anteriorly, and we went the transperitoneally, and this is how we achieve the proximal as well as the distal vessel control. These are the iliac vessel, you can see, and this is how we can use these vessel loops, and we take control of these vessels, so that even if there is a bleeding or there is any damage to these vessels, then we can just pull it up and we can just control the bleeding. So this is again a very important, and you can take the help of your vascular colleagues or the general surgeon colleagues if you have any, and if you don't have the experience of operating in this area. Now, this was a case of for solitary, the severe osteochondroma of the cervical spine, and this you can see here. This was a very big tumor, and it was also involving the vertebral artery. It was going into the vertebral foramen as well. So in these cases, also it is important that you expose the vertebral artery above and down, and in case of tumors it can be very difficult, but we expose the vertebral artery, and in the transverse process or the foramen transversorium, it can be useful landmark, and always better to expose the vessel between these two landmarks. So this is like after the tumor removal, you can see here the vertebral vessels, you can see here that they were exposed very carefully before taking out the tumor. If you have a vertebral artery injury, then it can be a problem, but always evaluate the bilateral vertebral arteries pre-operatively if you are going to operate in that area. If you are putting a screw, pedicular screw, and you look at that there is a vertebral artery injury in the screw hole, then you can put just the screw there, and it can be taken care of. But some surgeons, they also, they contradict this way, and it's a controversial view, but most of the authors, they agree that you should put the screw in the vertebral artery injury hole. If the vertebral artery injury is in the open space, then you can obviously use the tamponade. If you are able to repair it directly, or you can use the endovascular management, or in extreme cases, if there's no way, then you can just ligate it with its own consequences. Other hemodynamic measures which we use, we can use the local vasoconstrictors. Like some surgeons, they prefer to use the epinephrine before skin incision. Also, the epidural blockade has been shown to reduce the blood loss during the surgeries. I don't use them, but these are again the methods described in the literature to control this thing. Tranexamic acid has come up a big way in spine surgery, and people have described various doses and the routes, including the topical use of the tranexamic acid. At my institute, we use a 15 milligram per kg IV stat at the induction, and we usually give it over the 15 minutes, and then we give 1 milligram per kg infusion per hour. It is important to know that the tranexamic acid doesn't seem to have an effect if we are operating a case of spinal metastasis. So you have to be very careful. Other agents have been described in literature like recombinant factor 8, desmopressin, aprotinin, epsilon amina caproic acid, and estrogens. But again, these are all used by different authors and different surgeons, but we don't have any experience with that. Once you have bleeding, then you always look for the blood pressure. If the blood pressure is too high, then ask your anesthetic friend to control it. Bipolar cauteries, you can use the thrombin mixtures like flow seal, gauge. Again, just by pressure, the gauge can also affect the bleeding. Control bleeding, gel foams, Surgicel. If you are having a bleeding from the bone surface, then bone wax has to be used. This is the basic course. I'm covering this thing. Like the bipolar cautery is very essential if you are working around the cord or around the nerve root, especially around the epidural vessels. We have the luxury of molecular resonance cautery, especially if I'm doing an epidural work. Then I can use this molecular resonance cautery. The important thing is that it coagulates at less than 50 degrees centigrade. So again, it is very safe if you are working around the cord. We also use the ultrasonic scalpel, and there are various studies, and they have shown actually that it reduces the blood loss during the surgery. Like this was a 3-year-old boy with severe kyphotic deformity, and I had planned a vertebral column resection. Now we all know that the vertebral column resection surgery, the average blood loss is around 2 to 3 liters, but actually the whole volume of this 3-year-old boy will not be more than 500 to 600 ml. So again, we use the ultrasonic scalpel, and you can, the people who operate these deformities, they know that if you are using osteotome at this step, that how much bleeding it usually encounters. But with the help of the ultrasonic scalpel, you can see that there's hardly any bleeding you can see when taking out the pedicle in this area. And this is the cuts which we have taken, and this is the post-op, the intra-final correction, and this is the immediate post-op. So coming to hemostatic sponges, we have various agents available like gelatin-based, but again there are concerns of the allergic reaction and the neurological deficit, because they can swell, they can absorb blood, and they can swell up. So I don't leave any of these gel foams near the cord. If you are using the collagen-based this thing, then again they can swell up and then they cause compression. Cellulose-based like Surgicel, they can cause neurological deficit, and they can also cause the epidural fibrosis. People have also reported the pseudotumors or the images of herniated disc recurrence if you are looking at the post-op MRIs. So people have actually described the different sort of hemostatic agents depending upon the location of the bleeding. But in my practice, I usually just prefer the gel foam. Like gel foam is usually able to control the bleeding most this thing. Just put a little bit pressure with the help of the gauge over that, and then the other thing is like you can use the fibrin glue, especially if the bleeding is coming from the anterior cancellous body, and you can just superimpose gel foam on it, and most of the times it usually controls the bleeding. One word about the controlled hypotension. The people have used the controlled hypotension. It is very important that if you are working around the cord, if you are doing an osteotomy, at that step the blood pressure should be more than 80 millimeter of mercury. The mean arterial pressure should be more than 80 millimeter of mercury. For exposure, you can use the controlled hypotension, but whenever there is a manipulation of the cord, at that time, your mean arterial pressure should be more than 80 millimeter of mercury to preserve the circulation of the spinal cord. To summarize, the hemorrhage during spine surgery can be a big concern. The prophylaxis is always better, prediction is always better, and whenever you are doing surgeries, use all possible parameters to decrease the risk of bleeding. And I always say to my fellows and my students that in spine surgery, time is actually blood. So the more time you take, the more blood you lose. So just finish everything, whatever steps you can increase. You can hasten always to the spine surgery. The exposure part, you can use 2 surgeons, they can operate and they can decrease the time. And do not hesitate to call your vascular friends if you have any injury or anything. Thank you.